On behalf of our president, Dr. John Ferretti, and our provost, Dr. Sylvia Ferretti, I'd like to welcome you to Research Day here at the Bradenton campus for 2016. Special welcome to our special guests, our panel members, to the dental students, farm students, medical students, and the faculty that have come together today for this special occasion. My name is Tim Novak, and I'm the director of the LECOM's School of Graduate Studies Masters in Health Services Administration program. And it's my pleasure to host today's case panel discussion and moderate as well. A couple housekeeping things before we get started. Number one, if you would please silence your cell phones just to make sure that we don't have interruption during the panel discussion today. Also, as we're starting now, we would ask that everybody remain in their seats during the program, as we're privileged to have Manatee Educational Television filming this event today for us. And by remaining in your seat, this will be your consent to be filmed and to appear on TV as they're producing this program as a healthcare special. All right, let's, and I also want to put out a special thank you to Dr. Schroeder, Dr. Vasquez, and Dr. Louisa Ward for their coordination and efforts and everything in putting this day together. They are your faculty representatives that have really made a research day possible, as well as our Vice Provost, Dr. John Angeloni. So, a big round of applause. It's my distinct pleasure now to introduce you to our panel members, which I'll ask to introduce themselves briefly. And we're going to start with Dr. James Lynn.
Thank you, Tim. My name is James Lynn. I'm a graduate of LECOM from 2002. I also graduated residency program from LECOM Health, Mill Creek Community Hospital. Did my fellowship in geriatric medicine at UMDNJ. I'm currently Vice President of Senior Services and Adult Living for LECOM Health, and I'm a Program Director for Institute for Successful Aging, Course Director for Geriatric Medicine, and also recently LECOM received the HRSA grant called the Geriatric Workforce Enhancement Program, and I'm the Program Director for that program. So thank you for having me.
Good afternoon, I'm Karen Reynolds. I'm a clinical nurse specialist and advanced practice nurse at Sarasota Memorial Healthcare System. I'm also an adjunct faculty at the State College of Florida. I got my doctorate of nursing at the University of Florida. I got my master's at Andrews University, my bachelor's at Kent State. I am an Air Force nurse veteran, and my claim to fame is I threw out a first pitch at a Rays game.
Welcome.
Hello, my name is Harry Hobson. I'm President and CEO of Plymouth Harbor. Plymouth Harbor is a continuing care retirement community here in Sarasota, just west of the very, very slow John Ringling Bridge right now. And on that 17-acre campus, we have independent living, assisted living, nursing home, and home health care. Prior to that time, I was with the Holy Cross Health Systems for a number of years. I have a master's degree in both business administration and healthcare administration, and also a licensed nursing home administrator. And thanks for having me today.
Hello, I'm Marcus Campbell. I graduated from the University of Florida with Doctor of Pharmacy and completed an ambulatory care specialty residency in pharmacy there. I went on to do a 2-year fellowship in pharmacology toxicology, and currently I am an assistant professor at LECOM School of Pharmacy and work as a clinical pharmacist, ambulatory care pharmacy specialist with Tampa General Hospital in one of their outpatient clinics doing diabetes management.
Good afternoon. My name is Jennifer Bensey. I'm the County Health Officer for the Florida Department of Health in Manatee. I've been with the Florida Department of Health for over 20 years, running health departments and also a division of emergency medical operations in Tallahassee after 9/11, overseeing the preparedness and response for the state, as well as the trauma, EMS, and rehab systems. And I have a medical degree, a master's in health administration, and my hobbies are travel, beagles, and rowing.
My name is Joel Felsenfeld. I'm currently a assistant professor of restorative dentistry here at the wonderful LECOM campus in Bradenton. And I graduated from the University of Michigan, undergrad in dental school, for any of you that don't know. I did a 2-year externship with the Geriatric and Special Care Center of Michigan, and throughout my 28 years of private practice, I was also an attending GPR faculty at the University of Michigan Hospital, and I directed the 4th-year geriatric dentistry rotation at the Turner Geriatric Center and the Michigan Hospital. And I'm glad to be here in Florida, and my claim to fame is I also threw a first pitch out at a Pirates game, and boo, and just let's get going.
All right, very good. Very good. Thank you very much for our panel. And as you can notice, when we talk about interprofessionalism, obviously we've got people from with different occupational training. We have MDs, DOs, dentists, administrators from health department. And the reason we have it is because interprofessionalism, working together, requires us as a community to work together as healthcare professionals. Now, this is not something that has come easy or is being adopted quickly, but it becomes, as we see an aging population, as we see the level of complexity of the patients, some of the social issues, the economic issues that are facing us, is that it's no longer something innovative or nice to have type of a thing. It becomes a moral imperative that as professionals, as you sitting there as students of dentistry, medicine, and pharmacy, that you prepare yourself not only for your core, but to make sure that you can work with those people that you're going to need in order to take care of your patients and give them the very highest quality of care within what the community will offer. So as we break it down, and that those who know me, I teach communication, so I always break down and see what the word means. Interprofessional, if you take a look, inter is a prefix from the Latin, which means between and among. And then professional as a noun is a person engaged and qualified in a profession or occupation. So putting it together, we have between persons engaged and qualified in professions or occupations. And that's what we're going to talk about today. A little bit of how this is going to work. So what we have done is that we have distributed to the students and faculty a list of indications for a patient that we're going to discuss today. This is not an unusual case. This is people that live in your neighborhoods. This is the guy that lives next door. This is the person you're going to be taking care of. We have an 83-year-old Hispanic American, a retired custodian from a high school, who has been a widower for 5 years, lives by himself. His primary source of income is his Social Security, some interest off the savings in which he's accumulated. He has 3 children that also assist, and that he has presented in the dentist office today for issues associated with, or concerns of his family members, his son specifically that brought him in, that he's no longer wearing his denture and is not eating regularly. So the point of entry into the continuum is different places. And so today it comes in through the dentist office. And what we're going to do here as we go through this is that the panel, we're going to start with Dr. Felsenfeld, because he's the first stop on this. And then we are going to talk about the 4 domains of interprofessionalism. And you're going to observe those 4 domains and how they work. And what are they? I mean, the first is values and ethics for interprofessional practice. It starts with a climate of mutual respect. You must respect each other and what each other can do to help you take care of your patient. Know your limitations and be able to seek help openly for those things you don't know. What is your role and responsibility as a second domain? What do you know and what things do you need to go out and find assistance with? Interprofessional communications. How are we going to communicate among each other? Listen, we live in a world where HIPAA requirements and disclosure of information is serious business. And so in a forum like this today, if this was a real patient we were discussing, we would have HIPAA disclosure statements signed by everybody, even the panel members that were there. So patient confidentiality is essential. And then for an underlying theme of teamwork, you start with the basic thought is that how can we work together as a team? How can I expand my success as a provider by working with others and forming a winning team? So with that said, we'll go ahead and begin with the panel, and I'll turn to Dr. Felsenfeld, who will give us a start of the patient.
Okay. Do they have the breakdown of all the information?
Up on the screen throughout the presentation, there'll be on 1 minute cycle, you'll be able to see the various indications of the patient, yes.
Okay, this is not only an interesting situation, but comes up more than you think. And what I mean by that is dentists can be the primary care provider for a patient with a myriad of both dental and medical issues. Now, from this information, here's what we know. We have a complex medical, dental, psychological, social condition. And in order really to get the best prognosis, this would need a team approach. And we as dentists are obligated to give our patients the best prognosis, even if it involves working interprofessionally with people who are experts in their field. The final goal is to get this patient healthy, maintainable, and get the best, I'm going to say, value and success from our treatment as dentists. So it's important in your offices that you have a list of professionals that you can work with. Fortunately, I was able to work in a geriatric center that was multidisciplinary, and what a great opportunity to manage these patients. So I'm going to start. Obviously, the patient comes into our office and they have a chief complaint. And we all know, all our dental students know, is we have to address that chief complaint. So he comes in with ill-fitting dentures. We examine the patient. We find out he has a unknown palatal lesion, exophytic lesion, that we have to determine what it is. Okay? So obviously, he's going to get a biopsy, get it diagnosed. Okay? And our goal is eventually to be able to have the patient function well. But he has so many other issues. And we would want to do sort of a patient assessment. And we as dentists can do this, okay? And especially with geriatric patients, you know, it's unique to older individuals because it needs more sort of a symbiotic relation between all the different specialties, okay? And we have to determine, how is this patient going to function in the environment? Does he need an inpatient, outpatient, short-term, long-term care? We have to understand things about pharmacology, social support systems, psychologic and sociologic variables, and how is our oral plan going to fit in with his whole health environment. So this is something that I feel I'm very passionate about, and I think it's very important because our role as dentists can be extremely important in the management of people like this. So when a patient like this comes in, as far as in my practice or my experience, is to develop sort of a care plan, and we use the mnemonic of OSCAR, O-S-C-A-R. And that gives us a starting point of how we're going to use all the other resources that we have. So we have the O, which stands for the oral health and needs, and we're experts in that, okay? But once we start going on and we get into the S phase, which is the systemic factors, we need help and be able to communicate with other professionals. So our treatment plan can be tailored for the best result because I'm not an expert in some of those other things. So we may need a good evaluation from a geriatrician, maybe a nurse practitioner who deals with geriatrics, pharmacology plan. Once we get into the capabilities of the patient. Do they need assistance? Can they take care of themselves? I may want to go into the public health assistance and make use of all the resources that Dr. Bensey has in Manatee County for this patient to be able to get to appointments and to improve. Then we have issues of the A is autonomy. I may want a geriatric care manager to assess the patient along with maybe a long-term care facility that they're going to be in and get the communication lines connected. And then we have reality issues, life expectancy, prognosis, medical stability, which may even involve legal, family, and psychiatric and social help. So this is why it's kind of important to understand your role is when a patient comes in and you're the primary care provider. And it's so important that those lines of communication are open and they're constantly being information back and forth. Because when you practice in this little cocoon, the patient suffers. And we have an obligation to be able to offer our patients the best quality care, also keeping that care at a good cost. So my first referral here would be a geriatric evaluation. And obviously once we know a diagnosis and a plan as far as what it is, I would want to talk to the geriatric physician what their plan was and coordinate my treatment with it. So I would hand them over to Dr. Lin to take over from here.
Okay, thank you. So as all of you know, taking care of a geriatric patient is very complex, and as osteopathic physicians, we look at the whole person approach, and geriatric medicine really demonstrates that. So is what, if I receive this patient from a referral from a dentist, typically what we will do in an outpatient setting, what we call a complete geriatric assessment. And what is a complete geriatric assessment? It's all the above that the doctor just mentioned, but it's a very thorough history and physical, and it takes, in our clinic, in our center, it takes about an hour, and we go through the detailed history and physical, but the domains that we cover is social aspects of the individual, their level of function. So what is the goal of this whole interprofessional team, and what is the goal of healthcare workers and this whole workforce? Well, our goal is to keep the patient functioning at the highest level, or keeping in the community so that they don't end up in a institutionalized setting, because it's quality of life as well as a cost. So in order to do that, as a geriatrician or as a primary care physician, our job is to do a thorough assessment and getting the history, but all domains of the history, the social aspects, the medical aspects, the cognitive aspects. And the reason for this is we got to be able to come up with those 14 bullet points up there. It's neatly packaged for us here, in this setting, but in the real life setting, it literally takes about an hour to an hour and a half to really get the answers to list out those 14 bullet points. For example, is the patient a smoker? What is the financial situation of the family? What is the social situation at home? What is the stressor at home, etc. And the fact that he's not eating because of this ill-fitting denture, that might just be a symptom of a bigger problem and stuff. And it's our job as a primary care physician to really find out all those problems so that we can list them all out. And each of these bullet points, our job is to really map out a plan for the family and for the patients to follow. So in this particular scenario, in this particular case, this is probably 90% of the patients that I see in the geriatric center up in Erie. And typically what would happen would be, at our Institute of Successful Aging, this patient will come in as a new patient. Prior to the patient receiving the medical evaluation, we will probably have the patient and the family sit with our MSW, the social workers, to go over all the social aspects of the patient, what are the needs, and identify what the patients need in that fashion. And she's already beginning to plan what resources that individual will need in the community. And then after that evaluation, then we'll move the patient into our medical evaluation in our clinic room, which is a typical evaluation room. And then the geriatrician will come in and we'll do the complete history and physical. We'll do a cognitive screening, and then the geriatric depression screening. And if any of these things were positive, we would then refer the patients out to our neuropsychologist, which is right in the office. And if need be, we have a neurologist in the office as well. And then finally, we will also do laboratory testing to make sure that there's no underlying metabolic or any medical abnormalities that's causing these subtle symptoms. And the signs, and in this individual, they present it because the individual can't swallow. But if you look at those 14 bullet points up there, the individual may be depressed. The individual may begin to have an early signs of cognitive impairment, that forgets to eat and forgets to do oral hygiene, and that's why we're having these issues. And you look at that history, you know, to get an 83-year-old individual to tell you how much they drink, what is their history, and all those type of things, you got to start to think about, well, they're not really eating. Are they by themselves? So who's preparing the food? So is he not eating and he's just drinking beer and drinking wine, and now he's cognitive impaired, and now he's losing weight, and now he's having an ill-fitting denture? And these are all the problems. So you can see, you know, it's, by the time we see all these people, it's just the signs and symptoms that we're seeing in the phenotypical way. But our job is to find out what the root cause of all this problem and come up with a plan so we can help solve each of these bullet points and stuff. And this is an individual that can enter into an acute setting. This is an individual that I would call very frail, and that can easily end up in an emergency room. And then if they end up in an emergency room, the cycle and the process of getting this individual back to a community setting or the highest level of functioning requires all of the panels that you see up here. So for example, this individual were to fall, where now he's dehydrated and he's got mental status change, the individual may be going to the emergency room via EMS, and that's where Dr. Reynolds would come in, because if the patient ends up being a acutely ill individual and ends up in Sarasota Memorial Hospital, then there's a whole host of different things that we have to do to get this individual back to prior level of function or into the community. And I'll let Dr. Reynolds tell you, assuming this individual, I do the geriatric assessment, and we found out that this individual is somewhat depressed, somewhat has a cognitive impairment. We also review the medication, and our clinical pharmacist in our office has reviewed and make sure that the patient are on this medication, that's the correct list. And now individual, I find that, for example, this individual is dehydrated, he's got an acute mental status change, I think there's something medically going on. I need to refer this patient or send this patient to the hospital for further workup, and that's where Dr. Reynolds comes in her expertise in the acute hospital setting, and then I'll let you discuss what would happen if that was the case.
Thank you. So not only does interprofessionalism happen outside of the acute care setting, but it's very imperative to occur as a culture within the acute care setting as well. And so I work on a multitude of interprofessional teams right now, and we're finding that, again, the culture is changing and the tides are changing, and it's specifically beneficial to our geriatric patients as they are in the acute care setting, where it's not multidisciplinary, where it's siloed, where each individual comes in and cares for an individual element or entity, but it becomes that we all are aware of what each other's role is with this patient and also their level of expertise, and everyone brings a varied level of experience as well. And that's where that mutual respect, I think, as one of those domains is important to consider, especially in the acute care setting. So for this particular individual who comes into the hospital, again, my area of expertise comes with with change in cognition, and I focus on delirium. So delirium is that acute, sudden change in cognition, and is very important and considered a medical emergency just as much as any other acute organ failure in older adults. And so as we look at what were contributing factors for this individual before he came into the hospital, he had some alcoholism, he had dehydration, so he had some contributing factors. He also may have had an early dementia, which may predispose him. But as we look at that, again, it's not that we want to forget the head in the bed, and I think of this all the time, and this is, again, my platform for when these individuals are, I'm advocating for them, is, you know the adage, no child left behind, no brain left behind. I mean, we cannot just leave that cognition as a normal function of aging. that these individuals come in and their mortality is dramatically affected by any change in cognition that occurs to them. 33% of them that come into the hospital, as this gentleman may have come into the hospital, go out and die within a year after their admission, simply because of the fact that they had a sudden change in cognition. So just as much as we look at the multitude of factors, we have to look at what then could be contributing and what we caused maybe by medications that we have added that may not have been beneficial for this individual. We have to weigh the benefits and risks. So that's where we collaborate all as a team. We get physical therapy involved, occupational therapy. We do multidisciplinary or interprofessional, rounds within the format of the unit, and everybody talks about that particular patient with the common goals. And so I'm going to go ahead and turn it over to Dr. Campbell to talk about some of the pharmacologics that maybe and interprofessionally what we can look at for this particular case.
As Dr. Yen said, in his center, a pharmacist would be involved in that initial medication reconciliation, and not only collecting the medication list, but ensuring that the patient, or assessing that the patient has been compliant with that list by contacting his community pharmacy. And truthfully, the pharmacist is involved in that transition of care, medication reconciliation at all points, at all handoffs across this, and potentially could have even become involved in this before the patient presented with these acute problems, because there was a community pharmacist or a retail pharmacy somewhere dispensing medications to this patient that didn't recognize signs and symptoms that were occurring. Presented there, ends up here, we do a medication assessment. Dr. Yen and his team put together a list of medication problems, medical problems, and I work with him at that point to optimize the patient's medication list, to make sure that we eliminate or reduce any chance of drug disease and drug-drug interactions. And if the patient comes into the acute care setting, we're doing that at the time of admission and again at the time of discharge. And ultimately, at that discharge point, then we are all working together as a team. We're meeting in interdisciplinary rounds, probably daily for this patient while they're inpatient, while they're in the acute care setting, determining their level of status before they came in and what they're capable of being discharged to. And ultimately, at that point, we probably are working with someone like the Department of Health, Manatee Department of Health, to transition this patient back out into the outpatient world, and so that she can find a place ultimately for him to settle in.
Right. So I'm just going to, so in that scenario, Dr. Campbell will be doing all the medication reconciliation and those type of things. So as we continue to follow sort of the progression, part of the Department of Health support for the community is preventative health. So this individual, when they come into the outpatient setting, I already have asked whether or not the patient is vaccinated for pneumovax or for a flu vaccine. And then also, as the patient sort of leaves in this direction in acute care and then transitions out to the community and stuff, there's a very important part of the transition. So I'm sure all of you have heard in the news our efforts to reduce 30-day readmissions and stuff. And how do we accomplish that? Well, we accomplish that through using Mr. Hobson's level of expertise, because he's got a different level of continuum in his community. So, the question is, does this individual need a skilled nursing facility to transition the patient back into the community so that all the community program would support the individual to stay at home? So, I don't mean to cut you off, but I just want to give the opportunity, since we're following the acute care sort of progress, to illustrate to the students and the audience how that would occur, and then maybe you can hand off to, after you're done with the patients in your community, how that would transition into the community, and then from Department of Health perspective, you can tell us how we maintain this individual in the community, and finally going back to oral health, how we actually get the individual the dentures and all that type of stuff. So.
Okay. Well, I tell you, and we're going to move right to that, but I do want to take a question from the audience, because there may be some questions, and that so if somebody has, if they would stand up, say your name and what year student you are and what school, and then state your question.
Okay. My name is Akash Gohel. I'm a P2, a second-year pharmacy student, and my question for you guys is: you guys stated cost is a big problem, or it's something of an issue. So my question is to any panel member, are there any benefits or services that might help this patient?
Yeah. Well, let me just add just a bit. Again, I'm Harry Hobson. Any services that could help this patient, we're going to receive a heads up either directly from Dr. Lynn or possibly Dr. Bensey's, maybe through a case manager. And at that heads up, we would ask the question during the assessment process. As I look through the case, I question whether that person does have a safe place to return to for a fairly extended period of time. Let me just say a week or two. I see a suicide risk, I see dementia possibilities. That sets off a lot of alarms with me. So I would offer to bring the person to the team. It would not be my call, but I'd be receptive to bringing the person into our transitional care unit where we could monitor that person 24/7 under your direction. And the longer, if it looks as though the person will be cared for in that kind of environment longer term, I'm going to go back to Dr. Bensey because I'm very aware of telemedicine or telehealth health with the VA. And I know that this patient was a Korean veteran, but I don't see any indication of VA benefits. And if we could bring a very cost-effective telehealth benefit to this patient, and I believe it's $1,600 a year, would be something that at least I'm sure our team would put forth.
Can you share a little bit about the telemedicine program, what it's about through the VA?
I'll talk about it to the extent that my YouTube knowledge will kick in. We've not used it directly, but I certainly am very aware of telehealth. And that's where, let's say at a Plymouth Harbor Care Center, that person would be housed safely, cared for. We'd be dealing with and trying to enhance their social interactions. And then if we were going to interact with the physicians here on the panel, simply the person would be walking down the hall to a dedicated room. And if you can imagine a teleconference, if you will, directly with the physician, and where you're doing the vitals, et cetera, and it's the next best thing to a face-to-face visit. Am I close? Okay. So now I'm curious about benefits at that point. Our social work department can dig into the benefits, et cetera, but I probably wouldn't do that alone without at least crossing over to public health and asking your thoughts on it.
Great. Thank you. I'm so pleased to be here today. My role is to make sure that the healthcare system in my county, which is Manatee, is integrated, and each of my peers across the state has that same role, first and foremost. So how do we do that? We look at population health, right? We're talking about every single patient like the one we're speaking of today in our community, whether a resident, visitor, et cetera. So what happens is, in our case, we put together the Manatee Healthcare Alliance. It's over 50 partners. They can be healthcare providers, persons interested in healthcare, Chamber of Commerce, insurers, hospitals, obviously the Federally Qualified Health Center. We have one of the largest in the country here in Manatee County with over 26 sites. So bringing all the partners together and say, how do we maximize our resources? We have a lot of resources. We're very resource rich, but how do we make those linkages so the patients, like this one we're speaking of today, know how to utilize the system for their benefits? So what happens was, in our community, coming together as the Alliance, we are focusing on 9 core priorities that came out of our CHIP, Community Health Improvement Plan, which was done after the Community Health Assessment. A lot of acronyms in government. But anyway, it's a requirement of all health departments across the country for accreditation to have a CHIP in your community. And it's also required for hospitals for Joint Commission to be part of this process. So in Manatee County, one of the top priorities obviously is access to care, regardless of your insurance status, if you have it or you don't have it. So one of the initiatives that we came up with, we were able to receive a grant for almost $1 million from the state recently to address primary care issues, and we're developing a community paramedicine program. So what does that mean? It means that either you call 911, the EMS comes to your home, assesses the situation. If you don't need to be transported, and right now at least half are transported, to the emergency room, because that's the only place you can. They can't transport you to an urgent care or somewhere else, so they automatically go into that system. If you don't need that, but you need services, like this gentleman would need a lot of different services that you've heard about so far today, the community paramedic can either be called by 911 or by a physician in the community, either through the emergency room or through a provider like what you heard today who's seen the patient and says, you need to go visit this patient at home. So the paramedic arrives, and not only in Manatee County does the paramedic arrive, but also faculty and students from LECOM School of Pharmacy arrive. And that way, we are looking at the medication issue. He's a diabetic, he's taking many, many drugs. How is the compliance? How is the understanding of these medications working? At the same time, we can talk about other issues that need attention. Does he need to be referred to a hospital, to an agency, outpatient settings? That is all done by the community paramedic. The goal, obviously, to keep in communication with this client, finding out what medical and social resources are needed. Another factor is the Centerstone, formerly Manatee Glens. They are a part of this project as well. So the behavioral health issues could be analyzed, assessed by the person coming to the home as well to determine the next steps. And the same with the hospital. They're actually going to have a mobile unit, Manatee Memorial, so that if the patient can be transported or has that transportation issue, which is usually the main issue for any of these clients that we're talking about today, transportation is instrumental in determining their compliance. So all these factors coming together to make it more convenient to get to the client and discuss those medical and social issues. How many of you are familiar with 211? Can you raise your hand if you're familiar with 211? Okay, we all know about 911. 211 is in every community, and it's through the United Way, and it's a resource guide. You call 211 literally on your phone, and you ask them, where can I find a resource for X, Y, or Z? This is the book. People don't know about it. So that's going to be another way that the community paramedic can assist the individual and their families in getting the resources that they need. Probably the biggest hurdle, though, that we're facing, and you're not unfamiliar with this, is the electronic medical record, the information of exchanging across different agencies, that patient's information. We still have work to do there. That's probably what's holding us back more than anything. But the bottom line is, you're hearing today, it's all the partners in the community coming together to maximize those resources to make the patients healthier and staying at home, staying out of the emergency room. Sometimes the hospitals can be the worst place for people to be. So if there's a better place for them to be, and they don't need to be there as long or to repeat those visits as often, that's what we're here for.
Thank you very much. So it's clear, as you can see from our initial pass through the panel, that there is an enormous amount of knowledge and services that can be provided to the patient, okay? Some of the limitations are, again, the information technology. These days, as we live in the world of the cloud, everything goes up into the cloud, and supposedly you can share information. In healthcare, we have limitations as to protecting confidentiality and what can be shared. Somebody's health record getting out can do harm to them professionally, other ways, and that it is a promise of confidentiality. So as we see our systems from a business side come on, where if they present to Dr. Felsenfeld and that he's on the exact same healthcare system, so when they go over to the geriatric center, where literally information can be confidentiality maintained and passed in a HIPAA-compliant manner, that movement of information goes a long way. Because, again, faxing things and sending things is a very dangerous game to be. I wanted to see if we had any other questions in the audience that we have. Yes,
Hello.
sir.
My name is Alpha. I'm a second-year pharmacy student. My question is for Dr. Reynolds. I wanted to know, how do you see nurse practitioner, intern, and the interprofessional communications. Thank you.
Thank you.
So advanced practice nurses, there's actually 4 different types of advanced practice nurses within nursing. There's the clinical nurse specialist, which I am. There's nurse practitioners, nurse midwives, and nurse anesthetists. And the role of the advanced practice nurse is really to work to our full scope of practice. And there's really different states right now have different variabilities with the scope of practice for nurse practitioners and for clinical nurse specialists, advanced practice nurses. So one of our initial goals is to make sure that we maximize our scope of practice within and reach our full scope in caring for individuals. But in actuality, the nurse practitioner and the advanced practice nurse, the clinical nurse specialist, can fulfill that role of a primary provider, especially for our ever-growing geriatric population, as they work under protocols, as they work under and again, interprofessionally, well with therapists, with physicians, with pharmacists, with the health department, in coordinating that care. So I really think that is going to be a really vital progressive role as we move forward too, and to help coordinate that. I wanted to add something too about the teams too. So we'd be remiss if we didn't have families as part of our interprofessional teams too. So I want to make sure that that's going to be something that, again, as we move forward. And also, we always have a clinical systems person on all our interprofessional teams for that whole integration of technology. So
very good. Technology. Wondered if Dr. Campbell could comment a little bit about people accessing drugs from CVS, from Walmart. I just heard that one of the major big box carriers has curbside service now, where you can literally use an application on your phone and an hour later roll up to the curb and get it. So with that type of easy access or whatever, how do you coordinate knowing enough about that patient, where dispensing that drug and the efficacy of dispensing it as in the role of the pharmacist?
That's a very difficult question to answer. Ultimately, we've come to a place where in some systems we are operating basically fast food pharmacy, and that poses lots of challenges. So pharmacists are certainly trained to acquire a full medication history and to work with the patients, but in that limited interaction it becomes a challenge. And that's coupled with no differently than in the physician setting, patients are seeing multiple physicians. Well, patients are also going to multiple pharmacies to pick up medications. And likewise, these pharmacy systems don't talk. Now, you may go to 5 different Walgreens. Those systems talk. But if you go to Walmart for one drug, Walgreens for another. And so ultimately, I think the best answer is that we encourage our patients to pick a pharmacist, pick a pharmacy, develop a relationship with them, for the pharmacist to develop that rapport with their patients, so that that interaction is a trusting healthcare provider interaction and not a fast food restaurant interaction.
Thank you very much. Definitely, again, a systems challenge, because unless they speak to each other, we don't know. We don't know. Another area I'd like the panel to address is the reality of the Affordable Care Act. And that as we see it, and that many that were covering the news yesterday saw that United Healthcare has recently is pulling out of the program, the current Affordable Care Act, due to massive losses, almost $1 billion in their first 2 years of it. And in Florida specifically, affects nearly 300,000 people that will have to find another carrier to take care of them. So anybody on the panel, as far as the impact about covered lives, the Affordable Care Act, and how it affects how interprofessionally you would, how does it limit you and how does it help you? Dr. Bensi, do you want to?
Obviously a very complex and sensitive issue for many people. I think that we have to look at the big picture and what are the positives. You know, no pre-existing conditions, up to 26 years old, although everyone would agree that those are positives that came out of it. I think when you come down and look at, you know, the states and where they are, you know, Florida did not choose to accept Medicaid expansion, for example. So what does that mean to us? And then I think it depends on the county at that point on how they want to respond. and take care of the residents in the community. So in Florida, it's done county by county, whether it's a tax, whether the community chooses to come together in some innovative way to address the situation. I would encourage you to go to the United Way's ALICE report, ALICE. It stands for Asset Limited Income Constrained Employed. It started at Rutgers, and they did 6 states the first year. Florida was one of them. They did 6 additional states last year. Now we're going into version 2 in Florida, and it talks about healthcare costs, but all costs. And for an individual family in Florida, $94,000 for a family of 4 is what is required for a stable situation, being able to afford health care, et cetera, $48,000 for an individual. So very complicated. It depends on child care, wages, transportation, all of those factors come into play. So when you think of medicine, it can't be just that, because there are so many issues that your patients are dealing with and choices they may have to make, which include whether or not to purchase their medications, for example. So just being up to date, and it changes daily. I teach public health administration, and you can't use a book. You have to go out every day and see what's happening, because things are changing so fast in our country regarding health care. So please understand it's much broader than what we call traditional medicine.
Thank you very much. Definitely ongoing and everyday real life, and as future providers in the continuum, something that you'll have to keep a close eye on as it progresses. One of the things that was indicated also in this particular patient is that at one point was an avid hunter, had rifles, that kept them at the house and those type of things. So this one for Mr. Hobson. So if this person decides and the group decides that coming into a community like his makes sense, as a Second Amendment right or whatever else, what's the status of his firearms, and how are you going to deal with that in case he wants to keep them?
I think I would rather answer the pharmacy question. No, but seriously, I think that what we would do as we interview that resident, we would want to know why the arms are important to the person. I think that's number one. Try to get a grasp on that. Because it could be a situation where the person could keep firearms off-site, let's say at a shooting range, because maybe that's what the passion is. On the other side, coming into almost any home when I see a dementia-related, it really starts to pull away from the statutes. What we would do is allow the person to have the firearms, but it would be trigger lock, the pin would be pulled from it, and no ammunition. And oftentimes what we find, and I spent some time in Virginia where that was a big thing, is that communication is important, because what they mean by keeping their firearms is they want it mounted and so they can see it. So it's understanding what that passion's about, and then I think approaching it as humanistically as possible.
Thank you. And we had a question. Terry, did you have a question here? Somebody had their hand up, one of the faculty members, I think, here. Did somebody have a question?
Okay, I'm Dr. Joseph Bukowski. I'm a retired oral maxillofacial surgeon. I practice in Erie for almost 30 years. And I think it's fine and good what you've said here, and I did that during my whole practice, the communication back and forth between the disciplines. But my chief concern here is still that the chief complaint of this particular patient that you mentioned here still will not be addressed, because someone brought out the point about the factor of cost. The only way this patient probably might be treated is if I found one of my colleagues who was altruistic and wanted to make that denture for the patient, because to my knowledge, the dental procedures that we need for an ever-expanding geriatric population aren't covered by Medicare.
Okay. Dr. Felsenfeld, do you want to address that one?
Boy, Dr. Bukowski, that is a great question. As I had said before, we'd have to address his chief complaint, and we would have to, I don't have a lot of information about the patient, but I'm assuming the denture is ill-fitting because of a lesion. And the issue is exactly what he said, is that these services, basic dental services, are not covered under Medicare. Sometimes they could be covered under, the surgical portion of it could maybe be covered. But what about an obturator? What about an implant retains something? Boy, we start getting into the real reality of healthcare, and that's where I guess public health would help me. Is there any place where they could go, where they could get either discounted dental care, like a dental school, or a residency program, where they could get high-quality care at a reduced cost? And that is a big stumbling block. A lot of times after the surgery, they just don't get the prosthetic done. And then we haven't addressed the issue of malnutrition, lack of eating, because he just doesn't have any teeth. So, wow, that's a great point. And that's something we struggle with all the time. I think a great thing is having the dental school here to be able to offer that kind of care. Graduate programs where you have prosthodontists and implantologists, even better. So that's something that we're still working. I don't know if Medicare will ever cover any type of dental procedure.
Right. Well, as we see, and also a disparity between acute medical coverage, right, for in general in the industry and people that have dental insurance. So if you're working and you're part of a company, sometimes that's a benefit that's available to you. But again, when you become Medicare age, et cetera, and that you're not working for it, the cost of having an insurance policy could be prohibitive. So that is one of the things. The cost issue is that, and it was a great one by the faculty, is that it doesn't matter, if you seek the help and identify it, if you don't have the financial means to actually get the care. And so this is why we take a look at the whole person, and the healthcare, the financial healthcare situation has to be fiscally solvent for this to work. Otherwise, it's a hypothetical exercise, right?
And there are some programs, for example, again in Manatee, we have what's known as We Care, and physicians, dentists can sign up and volunteer, and they're covered under the Department of Health for sovereign immunity. And so we have that at Turning Points, which is the homeless coalition in the community. Last year was the first time in Manatee County, the first time in Florida, RAM, Remote Area Medical, came to the state, and they'll be coming back this year to 7 different sites around the state, as well as coming back to Manatee in November. And for those of you who may have seen it on TV, it's very popular, started in developing countries, Appalachia, and it just demonstrates the need for this type of care, as well as vision and some primary care too. And basically a team comes in for a weekend, sets up in a community, and does 500 pairs of glasses made, sees 1,000 patients for dental care. But again, it's an in and out, but it hopefully can demonstrate the policy changes that will be needed to address the issues that we face in the healthcare system.
One thing that was available in Michigan that I became a part of was called the DDS program, which is a donated dental service. And, I would highly recommend, get involved in one of those programs. It wasn't that much time. We had to see 2 patients a year. Most of them were geriatric patients who did not have dental coverage. And sure, I made a lot of dentures, removed a lot of teeth, also saw patients who were post-cancer survivors that needed obturators, and the quality of life was improved so greatly. So if you could get involved in a program like that, this makes this a little bit easier, because once we as dentists put them into the main medical system where there is Medicare or insurance, sometimes they don't come back because they just don't have the finances to do it. And dental insurance, just think of it as a dollar subsidy. It isn't really insurance, and a lot of times it barely covers the cost of maybe even 1 denture. So making yourself available to these programs is a great thing for the community, and I enjoy doing it.
just really quick, is that as LECOM, we could be very proud in taking a look back over the last 12 months between our students and faculty in school, nearly $500,000 of donated services by the people that are sitting in this room who are taking social responsibility to take care of those that don't have the means to take care of it. And it's a beginning, it's a start, it's a toehold, but it's the type of level of care that's really going to be needed in order to keep this system sustainable.
Yeah, I just wanted to mention, and Doctor, what a great question and challenge for the panel. As I'm sitting here listening, I'm thinking of senior friendship centers, and that's here in Sarasota. And at the friendship centers, and it's located right at the split of 301 and 41, but they've got a clinic there. And that clinic covers many of the disciplines, including dental, and it's on a sliding scale all the way to 0. So if the person qualifies from a financial standpoint, they'll be seen, by a very, very fine dentist that can do many of the procedures. So that's friendship centers, and I'm sure there are, quote, friendship centers in other communities as well, but that's what we've got in the Sarasota area.
This one for Dr. Lynn, if you could just take a minute again and talk about some of the overall goals of the grant that LECOM's working with, and that how this can impact overall the interprofessionalism and also the impact the geriatric community.
Sure. So the main thing is all of us know that there's an increasing population in the geriatric realm. So by the year 2030, we're going to have over 75 million Americans over the age of 65. But along those lines, there are only going to be about 25 to 30,000 geriatricians, and then there's only going to be about 7,000 geriatric psychiatrists to take care of the cognitive impaired and demented behavior-related situations. So when we look at it overall, the population, there's a shortage in geriatric workforce. So HRSA wanted to charge the awardees, the 44 awardees, to increase education, interprofessional education, come up with a curriculum that all of us as healthcare professionals, whether you're a CNA, all the way through a physician, dentist, pharmacist, etc., we need to have the basic knowledge of identifying frail or high-risk individual that's eventually going to enter into our health system that's going to cost us a lot of money. And then our goal is to, with all the education and all the knowledge, is to keep this individual's quality of life at the highest level. So with this grant, our job is to really create, number one, an interest and an awareness for all the healthcare professionals that it is important to have this interprofessional education, because it literally takes a village to take care of one patient to make that individual well when that individual is sick. So that's one of the major goals, is to increase the number of healthcare professionals that understands the geriatric population with the basic knowledge of taking care of an elderly individual, no matter which healthcare professionals you are. And then number two is to inspire some of the young healthcare professionals like yourselves into really realizing that it is important to be part of this, whether you want to specialize in orthopedics, you want to specialize in any highly specialized thing that's a high-paying career, I understand. However, you might be donating your time, as Doctor said, maybe to help these geriatric patients, because it is important for our communities. So,
excellent. Thank you very much. So what is the way forward? What are we doing here? We have a unique opportunity here because as LECOM students, especially here at the Bradenton campus, we have dental, pharm, med, and School of Graduate Studies all right here on our campus. And that the idea as students and learning and as faculty members, we have a unique opportunity where we can meet, get together, and talk with people in different disciplines and learn from them. So the interprofessionalism starts today. The idea, we should not meet at graduation, right? We all sit together at graduation, shouldn't be that. Is that reaching out, if you're a dental student, and introduce yourself to a pharmacy student. If you're a pharmacy student, get to know some of the dental students, the med folks getting to know everybody. Hey, listen, over at the School of Graduate Studies, we teach the business of healthcare. It's not a bad group to get to know too, okay? So But it starts by wanting to do it, to know that it's okay, that we're breaking down the barriers and walls, and that you should be, and it'll make you better, a much more well-rounded provider, and it will make you more successful when you do enter into as being providers in the communities that you serve. And it allows you, as LECOM students and graduates, to become leaders. Because at the end of the day, it's all about leadership. You got people that follow, and that people that are hungry to be led, and that you lead by example. You, not what you say, but what you do. And so we're looking for today's panel, our initial discussion, the things that we started with today, is not the end of anything, but it's the beginning of it. And that we highly encourage everyone to seek out somebody, get to know people, learn from each other, and then be prepared for the next step, because I wish it was going to be easy and as a healthcare provider coming in the future, but there are many challenges, and the collaboration of interprofessionalism and the joy of doing it. Listen, this should be fun. This should be enjoyable. We should really take a lot away from this. Can exist if you got the courage to reach out. So we are going to go ahead at this point in time. I'd like everybody to give a warm round for our panel today.
I just want to charge you with being innovators too. I really want you to be innovators and partner and think outside the box with all of this, not just interprofessionally in healthcare, but outside, such as the example of Uber going around with nurse practitioners and vaccinating people. I mean, getting that access. So innovation and partnering.
Very good. Okay, so I would ask that as you're getting ready to depart, everybody's kind to each other in the parking lot, use reasonable safety. As you're departing the area, the dental students will stay in this room for your next activity. But at this point, we're adjourned. Thank you for your kind attention.
I am so pleased that I was invited to participate in this panel today, because it's exactly what the role of the Florida Department of Health is, and that's to make sure we have a robust, integrated healthcare system in every county. And today demonstrated how that happens. I believe today was an example of a microcosm of what happens every day in the healthcare system around the country. And basically, it's making sure that the patient has easy access to all the resources that are needed. And it's a complicated system. And so therefore, the providers need to know what the resources are and how to get the patient through the system to get the outcomes that are needed to become healthier. Yes, in Manatee County, we have the Manatee Healthcare Alliance, and the purpose of our existence as a nonprofit is to bring all the providers together in healthcare, as well as others who are interested, and that means businesses, that means individuals, obviously government, trying to determine, again, how to maximize our resources so that we are efficient and effective and also cost-effective in how we treat and provide care in our community, because healthcare is expensive, and obviously prevention and wellness are our main goals. If we can do that, then we avoid problems down the line. But people do need to get into the healthcare system at times, and how do we make that, again, as efficient and affordable as possible? Well, LECOM is a wonderful resource, and their approach to education, that integrated approach of mind, body, and spirit, really is vital. And also, as they mentioned, they also have a component looking at the business side of medicine. You cannot practice medicine in today's world without having an understanding of the business side of it, the financials, the insurance aspects of it, because that is something that won't go away, and that we need to make sure, again, that we understand how to navigate the system as efficiently as possible, so that the patient gets that timely treatment and the best treatment in the system. Yes, I believe regionally and statewide, we are trying to determine best practices, share best practices, improve the linkages, improve the communication, the integration of healthcare. We have wonderful resources in the state, but how do we make sure those linkages occur, whether it's from an information technology standpoint or it's a networking standpoint, transportation, all of those issues we need to look at and determine how to continuously improve the system so that we can be the healthiest state in the nation.
Because interprofessional collaboration is really the only way that we're going to move healthcare forward into improve patient outcomes, I think into the structure of healthcare itself, and access for individuals as well. It's really, again, collaboration and an environment of mutual respect. I think understanding more of the role and the scope and what everyone's experience brings to the table creates just a environment rich and welcoming for, again, advancing and improving those outcomes for the patients that we serve. I think families are very important as well to that interprofessional collaboration. Families, caregivers, those individuals that are part of the team. I think, again, one of my last statements included that innovation and that partnership and that ability even to go outside of healthcare within our own interprofessional environments and to look at those opportunities as to where we can provide the best service at affordable costs, again, and access. And it may be outside of partnerships outside of healthcare themselves. I think having knowledge of really what the demographics are within a county or within our communities is important. I think there's an again, aging community culture, and they are inherent with their own concerns and problems. There's food insecurities, there's homelessness amongst our older adults, and I think that communities cannot be unaware of those circumstances and have to look at those also and those challenges and also from a perspective of healthcare and meeting the needs of every community member.
Well, I think it's very important to demonstrate to the students that the interprofessional education and working collaboratively with their colleagues starts, right here in the educational level, and then they got to see the opportunity how when they're done with their training that a real life sort of interaction with the team should look like. So I think it was very important for us to demonstrate to them that it is very important, and that in order to make one healthy in that population level, it really starts from them, in school, in the classrooms. Well, the next steps are really to develop educational curriculums that would include all the healthcare professionals. In order for those barriers to be sort of broken, we can't operate in silos. So a nurse would have to work alongside the therapist will have to work alongside the pharmacist alongside the dentist. And when you have that, some of those barriers that you mentioned is just naturally going to go away because the practitioner is going to demand those things. And it takes a little bit of time, which is what the geriatric workforce enhancement program is all about. The HRSA wanted us to develop that curriculum at LECOM to help develop those type of training modules so that hopefully when these students get done out in practice, they could actually utilize some of the things that they've learned in school. Yeah, so our goal for the grant is at the end of the funding period, LECOM would have touched over 7,000 healthcare professionals, from students all the way through to practitioners that's already in practice. In addition, the disciplines that we're going to touch in terms of educating the healthcare professional in geriatric medicine is from CNA, a certified nurse's assistant, all the way through to a doctorate level of professional degrees. So you can see our goal is very ambitious, and we have a plan in 3 years that we're going to be able to accomplish that. And I think there's 43 other institutions doing similar things as LECOM. So when you add that up, it should be a significant number of programs that's going to get developed for the nation. Sure. So LECOM is a leader in developing healthcare professionals, not only here down in Bradenton, Florida, but also up in Erie, Pennsylvania. So the importance of LECOM is that we're training the next generation of healthcare professionals, and also in doing so, we're also providing the clinical services that's needed in the communities. So you heard in today's panel that our oral health is very important. Elderly people don't get enough oral health because there's not enough coverage. While having a training site down here in Bradenton, Florida, in Lakewood Ranch, as well as up in Erie, Pennsylvania, we have dental clinic here in Erie and Defuniak that provide access to these elderly individuals that may not otherwise have access to dentists, and you can see the importance of that as you listen to the panel this afternoon, that it's really oral health is very important, and that's just one example of what LECOM will do and provide for the community.
you know, participating in this panel was important to me for a couple of reasons. First of all, while I may be a CEO of a very fine organization, Plymouth Harbor, I also really want to be remembered as a mentor. So mentoring young people is very, very important to me. And we know that there are challenges in interprofessional communications. And I felt as though, at least from my chair, I had something to offer, some experiences that I could share with everyone. But I'll be quite candid with you. If I would have had an opportunity to ask one question, I would have put a question back to the audience. They looked bright-eyed, very intelligent. And what I would have said to them is, can you come up with that one big idea, suggestion, anything after listening to us today that you might add to our presentation from your perspective? How could we do a better job in interprofessional communications? Well, I think that's what we do. We really are there to help people. And I think the best way to help is with a team approach. Not one person or one discipline has all of the answers. So I think that one thing we can do is maybe monitor that process to some degree to make sure that when that older adult goes to the primary care, that it doesn't necessarily stop there. And by the way, I think that it's important that an older adult, when they do visit with the primary, if you will, that they bring a relative, a friend, because oftentimes we listen in the moment, and then we go back and we may reflect on something that was completely missed in that conversation. Well, I think we often hear the word that I want to age in place. And while I think that's important, I think that there's a word that we have to insert in that phrase, and I think that word is right. In other words, we want to age in the right place because it's important to us to maximize our independence, if you will. And oftentimes we can do that living totally independent. But that's what's beautiful about that continuum. If I need, let's say, just some assistance with my activities of daily living, if I could have just some assistance with that, well, then I'm maxing my independence most of the day. And then if the time comes that I need more chronic assistance, like a nursing home, that assistance is very important. And once again, at my stage in life, it'll offer me the opportunity to maximize that stage in life. I think what they should take away from this is that it goes beyond your specialty. Don't be afraid to cross those boundaries from one discipline to the other. I like very much the comment that was made toward the end where there's no better time than do that now. Do that while you're in school. Cross over from dental to medical. Don't be afraid to come approach the folks in the master's program in healthcare. If we get to know each other now, just think of how powerful we can be as a team later.
Hey, so that's a wrap today here at the Bradenton LECOM campus. We had a wonderful Research Day 2016. We've given our students, faculty, and community an opportunity to share some insights about the research that's taking place, the importance of interprofessionalism, and just how much talent that we have here in the community. So it was a pleasure for everybody here to be able to host, and we're very proud to be part of the community. And we want everybody to know that through our dental school, medical school, pharmacy school, and School of Graduate Studies, we're preparing the next generation of leaders here in the community.